Hi, everybody. Thanks for attending the sepsis webinar on EMS1.com. The webinar, it's getting hot in here, so why am I cold? During this webinar, our moderators, I will be serving as the facilitator for the webinar. I am the clinical education manager for Philips Emergency Care and Resuscitation business. Heather Cotter, who represents the International Public Safety Association, will be serving as today's webinar moderator. And our presenter today is Mr. Robert Moya. He is a paramedic instructor at UT Health San Antonio and the coordinator for the Bexar County First Responder Organization. His career as a paramedic and educator spans over 20 years, with experience as a combat medic instructor and leading various disaster relief operations. He is also the recipient of the American Ambulance Association Star of Life Award for Selfless and Exemplary Service in EMS. Now, before we get started, we're going to cover a little bit of general information about the webinar. So everybody knows this webinar is being recorded and audience interaction will be recorded. So your comments, you type in comments, and then the questions that we receive will also be recorded as part of the webinar. Also, keep in mind that the webinar is designed for educational purposes only, and we do not endorse or recommend any specific products, treatments, or therapies within this webinar. And most importantly, always adhere to your local medical protocols, because any of the information that we present here does not and should not supersede your local protocols. Now, without further ado, Robert, please go ahead, and I'm going to hand it to you.
Good day, Max, and thank you for that introduction. I want to thank everybody for joining us today. Always wanting to learn and wanting to join us. I also want to make sure that I thank every single person that's on here, healthcare provider, first responder, for their commitment to their patients, to the sacrifices that they make every day, and to the dedication to their profession as well. So let's go ahead and get started. What we're going to do is we're going to talk about and define what sepsis is. We're going to list the most common infections that lead to sepsis. We're going to distinguish between sepsis and septic shock. We're going to compare the two states of septic shock, and we're going to identify key indicators of septic shock. Along with that, we're also going to describe the relationship between end-tidal CO2 and serum lactate levels in septic shock. We'll identify the three predictors of mortality in sepsis. We're going to talk about the signs and symptoms used in the Systemic Inflammatory Response Syndrome, or SIRS criteria. We're also going to list the signs and symptoms used in the Quick Sequential Organ Failure Assessment Criteria, the QSOFA. As we continue through this, we're also going to discuss current research regarding pre-hospital treatment plans for septic shock. So the main thing that we want to look at is, why is being educated in sepsis so important? One of the main reasons that as providers, we just a lot of times don't identify that there is problems with sepsis. I spoke to a colleague one day about 2 weeks ago as I was putting together this lecture, and he said, the problem with us in sepsis, especially in pre-hospital care, is that it's out there. We see it every day. We just don't identify it every day. Sepsis is the 11th leading cause of death in the United States. So it's a pretty high amount of deaths that come from it. It affects about 1.5 million Americans and leads to about a quarter of their deaths. If you really look at the number and you look at what really is impactful to us, is that 1 in 3 patients who die in a hospital have sepsis. So that's a huge, huge number that we, as pre-hospital providers, can have an impact on. So what causes sepsis, and why do we have such an uptake in sepsis, and why have we seen it? If you look at the numbers that we currently have in front of you, those numbers are pretty high. I think a lot of it really has to do with the increasing elderly population that we have. Again, we are now starting to recognize the disease itself. We also have a rise in chronic diseases like end-stage renal disease. We have an increase in invasive procedures, And we also have an increase in indwelling devices and lines. These lead to some of our common infections. Lung infections, again, contribute for 35% of the disease that you're going to see. Kidney and UTIs, 25%. And the other two, GI infections and skin infections, attribute for about 11%. So again, we go back to what causes the problem and why do we have it. And looking at the things that I described tells us why we have such a high number in those two. So the definition of sepsis, it's pretty simple. I like using 25-cent words as opposed to $25 words. I can sit here and give you this long definition of sepsis, but sepsis is basically an infection or a pathogen. Most lay people will go ahead and call it a blood infection. I mean, that essentially is what we're looking at. Sepsis is defined as the presence of harmful bacteria and their toxins in tissue. We then start to worry when we go up to the next step, which is severe sepsis. Severe sepsis is, again, sepsis, the presence of the harmful bacteria, along with one or more signs of organ dysfunction, hypoperfusion, or hypotension. Once you start adding acidosis, metabolic acidosis, acute changes in mental status, decreased urine output, and the continuation of adult respiratory distress syndrome, then we really now start to see as we phase over into actual septic shock. Septic shock. Well, septic shock is basically, it's defined as sepsis accompanied by both, again, organ dysfunction and hypotension. That's not responsive to fluid resuscitation. And we'll be addressing the fluid resuscitation later. What we need to look at is we really truly need to look at what we learned back in school when we either went through medical school, paramedic school, EMT school, nursing school. Septic shock was categorized as distributive shock. And if we remember what distributive shock was basically an exaggerated systemic inflammatory response. The body's interaction with the body's immune response and the pathogen itself. There was an immunological reaction. It was caused specifically by the breakdown of cells and the production of endotoxins, which produce histamine. These combined together will normally lead to something that we call third space or third spacing fluid loss. If we really think about how the body works, and that's one of the things as paramedics and as medical providers that we forget, is that we need to know what normal is and what abnormal is and how the body works. That's why pathophysiology is so important to us. If you have third space fluid loss, this is going to lead to hypovolemia. And when we looked at the definition of septic shock, we said that it's sepsis accompanied by both organ dysfunction, hypotension that's not responsive to fluid resuscitation. If you're third spacing, you're now losing more fluids in the process. So why the title for this presentation? I always pick titles that are either a little bit witty, sometimes the witty comes through, sometimes it doesn't, or that can go back to giving you basically what the whole presentation is about. Our presentation was, it's getting hot in here, so why am I so cold? Some of you that know some of music out there and pop culture will know what that reference is. This really leads to what our next slide is. There are two states to septic shock. One state is the hyperdynamic state. All right. Initially, your patient will have increased cardiac output with decreased peripheral resistance. All right, again, let's look at that. It's increased cardiac output with decreased peripheral resistance. We know, again, pathophysiology-wise, that that's not very effective. In the hyperdynamic state, your patient will be febrile. They'll have warm, dry skin. They'll be tachycardic, and they'll be tachypneic, which means that they'll be breathing pretty rapidly. They might have slight altered mental status at this state. The next state is the hypodynamic state. In the hypodynamic state, your patient will have decreasing core body temperature. Their skin will be cool. They'll become diaphoretic. Again, they will have tachycardia, and again, they will also have tachypnea. Now they will have significant altered mental status at this point. Once the hypovolemia occurs, this is going to lead to decreased cardiac output and increased peripheral resistance. So again, let's review a little bit of this. Initially, you'll have increased cardiac output. Your heart will be accelerated. and you'll have decreased peripheral resistance. Again, that's not effective. Once the hypovolemia occurs, your body then goes into a normal shock state. This is going to lead to decreased cardiac output and increased peripheral resistance. Physiologically, what happens in these states is that there's a disparity between oxygen demand and oxygen uptake. Remember that your goal as a provider, as a healthcare provider and as a paramedic, I tell every one of my students this, you have one goal and one goal only, and that's to provide acidosis. Whether acidosis is a result of a respiratory problem, a perfusion problem, or a cardiac demand problem. Your job as a healthcare provider is to prevent that acidosis. As a provider, for us especially, our goal is to identify septic shock early while it's in the hyperdynamic state. So let's look at our assessment techniques and what we do to assess these patients. It's important that we perform a thorough history exam to include a sample history. Those of you in class remember what a sample history was. Remember that you are essentially a detective. You have to look for clues or attempt to contact family members for any additional information. If you arrive on scene, look and see, look at the environment around you. Is the heater on in the middle of summer? Is the air conditioning on at a very, very low setting because they're very hot? Is there tissue paper and Kleenex laying around the house? Is there over-the-counter medications on the coffee table? Go and look for these clues that can lead you to an identification of this sepsis. Identify any pertinent medical history. That's extremely vital. Has the patient been sick? Has anyone at home been sick? Have they seen their doctor? And if they saw their doctor, were they prescribed antibiotics? And of course, the important question is, have they taken their antibiotics as they were prescribed? We need to make sure that we also obtain vital signs. Your vital signs need to include a temperature, a blood glucose level, and an end-tidal CO2 level. We got to understand that patients with sepsis are going to present in many, many, many different ways, but a high clinical suspicion is necessary to identify that subtle presentation that they're going to have. Again, let's kind of break down a few of those. Do they have a productive cough? Is there sputum? Is the sputum white? Is the sputum green? Are they tachypnic? That's one of the things that we just don't look at. And I'll tell you the reality of it. It's first responders. We'll go up to the patient, we'll look at them, and we'll just do a full little scan and say, oh, they're breathing 18 times a minute, without truly looking and appreciating what the respiratory rate is. Tachypnea equals pulmonary dysfunction. Pulmonary dysfunction is going to lead and really be a definitive clue of sepsis. Do they have localized rales? Are they having altered mental status? If they have altered mental status, that equals organ dysfunction. Do they have diarrhea? Do they have difficulty urinating? Is there swelling or redness to their limbs? In the early stages, again, of sepsis, cardiac output is well maintained or even increased. The vasodilation is going to lead to warm skin, warm extremities, and normal capillary refill. We call that warm shock. I'd never heard of the definition of warm shock before until I started doing a lot more research. And they basically call that warm shock. As the sepsis progresses, stroke volume and cardiac output start to fail. The patient begins to manifest the signs of poor perfusion, including cool skin, cool extremities, and delayed cap refill. This is something known as cold shock. So now let's look at end-tidal CO2 and sepsis. End-tidal CO2 and sepsis is extremely, extremely vital. End-tidal CO2 period in pre-hospital medicine is number one, underutilized, and number two, not correctly used or looked at. End-tidal CO2 and sepsis is important because, again, end-tidal CO2 measures three things. It measures oxygenation in the body, it measures respiration in the body, and it measures perfusion in the body. End-tidal CO2 has an inverse proportion to the serum lactate levels in the body. Remember that normal lactate levels are usually 0.5 to 1 millimoles per liter. Where does lactate come from? I said your job as a provider is to make sure that you prevent acidosis. Serum lactate is basically a byproduct of cellular breakdown. As the cells start to break down, they start to produce acid. This produces lactic acid. So in end-tidal CO2, it's really, really, really simple. As the carbon dioxide levels start to fall, lactate levels start to rise. Right? As the levels start to fall, the lactate levels start to rise. So here's what we look at. End-tidal CO2 levels are an accurate predictor of mortality in patient with septic shock. And the research is a little, goes back and forth between it, but they basically both agree that end-tidal CO2 levels less than 25 millimeters of mercury are strongly associated with serum lactate levels of greater than 4 millimoles per liter. That's pretty high. I recently had a colleague that called me and said, hey, I just transported this patient. This patient's end-tidal CO2 level was 15 the whole time. Do you think I ever did something wrong? I wasn't bagging the patient, but I couldn't understand whether end-tidal CO2 was so low. When they got to the hospital, again, she had called me afterwards. She said, you know what? We got to the hospital and the patient's lactate levels were high and the patient was actually septic. So that was actually pretty neat to see it firsthand when it occurred. Severe sepsis is characterized by poor perfusion. This leads up to a buildup of serum lactate levels. Eventually, you're going to have metabolic acidosis. So again, we look at this. End-tidal CO2 levels decline in the setting of poor perfusion and metabolic acidosis. Basically, mortality in sepsis is going to be identified with end-tidal CO2 because if you have abnormally high or abnormally low end-tidal CO2 levels, there's a high chance of mortality for these patients. Abnormal end-tidal CO2 levels were found to be very reliable as lactate measurement in identifying severe sepsis. So now let's look at some of the criteria that we can use in pre-hospital settings and even in hospital settings, actually the most common ones that are used. The first one is the SIRS, or the Systemic Inflammatory Response Syndrome criteria. What we look for these patients is we look at their temperature first. We have to measure that temperature. I think as providers, that's another thing we just don't do enough. We don't get temperatures from our patients. Or if we do obtain a temperature, it's usually not a very reliable temperature that we get. The temperature of greater than 100.4 degrees Fahrenheit or less than 96.8 degrees Fahrenheit. Again, you look at the difference. 100.4, we're looking at a hyperdynamic state. At 96.8, we're looking at a hypodynamic state. A heart rate of greater than 90, a respiratory rate of greater than 20, again, we go back to that tachypnea. End-tidal CO2s of less than 32 millimeters of mercury. Remember, normal end-tidal CO2 is 35 to 45 millimeters of mercury. And then something that, again, we cannot reliably measure or even measure in pre-hospital setting is their white blood cell count. A white blood cell count of greater than 12,000 or less than 4,000. 2 or more of this criteria are met with or without evidence of infection. The patient meets criteria and we should begin a sepsis protocol for these patients. The next criteria that we can use to measure the sepsis or the criteria for them is the Q-SOFA, or the Quick Sepsis Related Organ Failure Assessment Score. This one, if you look at it, I'll tell you, as a paramedic, even as an instructor, I'm all about making things easy. This, we only truly need to measure 3 things. We need to measure blood pressure. Number 1 is their systolic blood pressure less than 100 millimeters of mercury? Is their respiratory rate greater than 22? And do they have altered mental status with a GCS of less than 15? 2 or more of this criteria, if 2 or more of these criteria are met with or without evidence of infection, we need to begin our sepsis protocol. So again, we look at our search criteria and we look at our SOFA criteria. Which one is best for me? So let's look at it. The search criteria. It's less specific at predicting mortality, but it's more sensitive at predicting mortality. Again, it's less specific at predicting it, but it's more sensitive at predicting the mortality. It's resource dependent, and it's good at predicting sepsis, right? It's good at predicting sepsis itself. The Q-SOFA criteria is more specific at predicting mortality, but it's less sensitive at predicting mortality. Again, this is good for low resource settings. This would be pre-hospital, in an ambulance, at a residence, at a home, someone. It's actually very good at identifying sepsis. So for us, basically, the quick SOFA may be better in the pre-hospital setting due to the limited resources and the need to identify patients who are at high risk for mortality. Conversely, SIRS may be better at identifying patients who are at high risk with severe sepsis, but it may not be suited for the pre-hospital environment because of the need to draw labs.
Robert?
Yes, sir.
Hey, can we go back there for a second?
Yes.
So it's an interesting, looking at these SEERS versus Q-SOFA criteria. This was a very interesting study that was done on the which one is better, basically. And what the study pointed at, and in regards to less specific and more sensitive and whatnot, is that utilizing the tools of end-tidal CO2 and blood pressure and heart rate and whatnot for the SEERS criteria, your patient does not have to be severely septic for you to begin to identify sepsis in the patient. So in other words, if your patient is starting to have these symptoms, right, they are probably going to become pretty septic later on, okay? And the Q-SOFA, on the other hand, is I think the point where if your patient is already experiencing these signs and symptoms, then the probability of mortality is significantly higher than some of the meeting the SEERS criteria. And I could see the Q-SOFA also being a really good tool for your BLS providers, because they don't have the tools that the capnography, the diagnostic monitoring equipment.
Correct. And that's a great point that you brought up on that. Again, we want to make sure that we're able to identify and be able to assess these patients all the way from the basic provider all the way to the advanced provider as well. So these are a great point that you had there, Max. So let's kind of look at the predictors of mortality. What's going to let us know as providers what could potentially lead to the mortality of the patient? Number one is we need to consider the type of infection that the person has. We need to look at the actual underlying disease that's going on with them. We have to look at their overall health. And we also need to look at whether or not the patient is of advanced age, whether our patient is an elderly patient, they progress in years, they're in advanced stage. If my patient that I've now identified as potentially being septic, if that patient, I am now starting to consider using vasopressors, if there's a need for mechanical ventilation, or they have abnormally high or abnormally low end-tidal CO2s, these are predictors of mortality. So we really need to start becoming very aggressive with these types of patients. So let's look at the current research and treatment. Essentially, as a pre-hospital provider, and especially as a pre-hospital administrator, because I worked as an administrator for many, many years, it always comes down to one thing for me. Is it effective and is it inexpensive? Because as a pre-hospital provider, whether you're a rural community provider or a busy metroplex provider, it always comes down to one thing, and that's price. Our treatments need to be effective. They need to be inexpensive. They need to be safe, and they need to be readily available. We've seen this readily available part throughout many years when it comes to medications. We had epi shortages. We had shortages of normal saline. You know, I used to joke around with my providers and tell them, you know, I can cry normal saline, so that means I'm carrying millions of dollars within me right now. The bottom line is that the treatment needs to save billions of dollars, but we also want it to save millions of life years. And at worst, if it doesn't work, all it does is waste a little bit of money and nothing is hurt in the process. And we don't have patients that are hurt in the process with it. One of the things that we want to look at, one of the first research studies that went out there was the MERIT treatment protocol. The MERIT treatment protocol is basically this. Again, we have to look at our research. Our research tells us we need to be able to treat the sepsis. We need to be able to manage the hypovolemia that's out there. We need to repair the acidosis, and we need to correct the nutritional deficit that's going on within the body. Infection uses a lot of nutrition. So we have to make sure that these patients have good nutrition within them as well. The MERIT treatment protocol was the first one that we want to look at. The MERIT treatment protocol basically recommended that 1.5 grams of vitamin C be infused to our patients over 30 minutes. They also said that we should administer 50 milligrams of hydrocortisone and 200 milligrams of thiamine. Normally what they would do is they would go ahead and mix the hydrocortisone and the thiamine together in a 50 ml bag, and they would infuse that over 15 minutes. So now you're looking at this and saying, okay, well, now this means I have a lot of work I have to do. If I have to start one infusion at 30 minutes, and then I have to start a second infusion over 15 minutes, now I have to start 2 IV lines. And those of us that have been working pre-hospital medicine for years and even in hospital medicine know that if you have a septic patient in septic shock, how hard it is to get those and obtain those lines. But it's important that we try to do that. Remember, our patients right now need volume. The protocol basically did this. The use of vitamin C, thiamine, hydrocortisone is believed to reduce stress, inflammation, and vasodilation in the patient. One of the things that the research showed, and not the MERIT treatment protocol, but other research showed, is that most patients in sepsis don't have enough vitamin C and vitamin D. Dr. Merrick's treatment protocol, basically gave us these findings. No patients in the treatment group died from complications related to sepsis. Rather, they died secondary to complications from their underlying disease. The study basically, all it did is, the results of the study were very promising, but it's important to remember that it basically gave us a hypothesis to lead forward on. Hey, is vitamin C going to work for us? Does hydrocortisone work for us? And does thiamine work for us? This opened up what should be more research coming to us as to the effectiveness of this type of protocol. Hypothesis that vitamin C, hydrocortisone, and thiamine have synergistic effects that reverse vasoplegic shock. Basically, they reverse the vasodilation. There's a potential limit on the duration of the vasopressor treatment, resulting in the reduction of organ and limb ischemia from vasopressors. By combining all this, we are able to affect multiple pathways with the added benefit of an overlapping synergistic effect on the patient. The next trial that came out was something called the HIPRESS trial. The HIPRESS trial basically said that early hydrocortisone administration could prevent shock by reducing the patient's inflammatory response. What they recommended we do is give a continuous infusion of 200 milligrams of hydrocortisone for 5 days, followed by a tapering dose until day 11. For pre-hospital providers, they recommended that we initially start with a loading dose of 50 milligrams of hydrocortisone. In our minds, we look at it and we think, yes, this should work. Hydrocortisone should help reduce inflammation. Basically, the study itself said that the use of hydrocortisone in adults with severe sepsis, not in septic shock, did not reduce the risk of septic shock within 14 days. The study was inconclusive. There's numerous studies out there. Right now, again, we are looking at sepsis as something that we are now trying to prevent and trying to treat, and the studies are out there and they're starting to come out. We just haven't been, I think, as aggressive as we should be out there, and I think Max, I would refer to Max on this one. I think Max would agree that the research that's out there was numerous, but we just didn't, we never could really come to a set black and white conclusion.
Yes, it's like Robert says, there's dozens and dozens, if not hundreds of papers out there regarding sepsis, septic shock, and pre-hospital and in-hospital treatments for sepsis. And it's interesting because, as pre-hospital providers, we don't, we look at these treatments, we're like, wow, I'm not going to give a vitamin C, infusion in the field, right? But it's the consideration of what you can do in that moment as a pre-hospital provider. And obviously there are many variables associated with that. How long am I going to be on scene? Can we readily transport the patient? And understanding that from urban transport time versus a rural or even a remote setting is going to help influence that decision as to what type of treatment you're going to want to give. But Robert, at the fundamental level, and I think we kind of covered this a little bit, but if you want to go ahead and elaborate a little bit more on the things that a pre-hospital provider can do in regards to treating a patient with sepsis.
So, and that's actually a great segue back to our next one, is that we can look at some of these other treatments that we as pre-hospital providers can actually provide for our patients. Number one, again, a lot of these treatments need to be effective, but they also need to be inexpensive, and they need to cause very little harmful effects to the patient. Number one, as pre-hospital providers, we've been taught volume resuscitation. If we get enough fluid into the vasculature to increase blood pressure enough to perfuse those vital organs. And depending on who we talk to, everybody's a little different. I think most standard research has told us that 30 milliliters per kilogram of IV fluid bolus works. I've seen it, I've done it, it works very well. I think I actually came from the paramedic mindset over 20 years ago that, you know, we gave a lot of fluids till we got that blood pressure back to normal. Well, research and current evidence-based practices have proven to us that that never worked, and it didn't work very well. What we need to do as pre-hospital providers is that we actually need to start looking more at our monitors. We need to, whether you like it or not, have to do a little Common Core math, and we actually need to look at volume resuscitation using mean arterial pressure. We want to have a map of greater than 65 millimeters of mercury. So the question comes, how do I determine map? Well, luckily for you, usually your monitor will determine the map for you. There's already a formula in there for you, so you can actually just read it on the screen. But if you don't have that luxury, remember that map is equal to the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. All right, again, a lot of Common Core math there that you're going to have to do. You're now dealing with a septic patient. The last thing in my mind is to try to sit there and figure out math for a map. So again, always look at your monitor. Your monitor would normally have a map there. A map of greater than 65 millimeters of mercury is going to perfuse vital organs, especially the brain, the heart, and the kidneys. Other treatment that we look at is the use of broad spectrum antibiotics or cephalosporin antibiotics. We always get questions where they're like, oh, you know, what should we give antibiotics? Should a medic be giving antibiotics in the field? I think this has been a long discussion between the in-hospital and pre-hospital personnel, because giving antibiotics in the field when you don't truly know what the infection is could potentially maybe cause some problems. I think as pre-hospital providers and as current base practice evidence shows us, there's not a detrimental effect to the patient by starting broad spectrum antibiotics in the field. One question that always comes up is, well, now my blood cultures are not going to be effective, or I'm not going to have effective blood cultures. One thing that we need to look at is that every facility, pretty much, even in your local region, every facility has a different process to get these blood cultures. They use different equipment, they use a different process, they use a different infection control process. So even as pre-hospital providers, if we wanted to get blood cultures for them, it might not meet their criteria. So you'd have to try to work together with your local regional area to try to come up with a simple process when it comes to that. The next one is the use of vasopressors, right? We use dopamine, or we can use norepi. Those of you that have been doing emergency medicine for a while know that norepi is known as Levophed. And for years, and I think Max could probably remember this as well, we used to use the term leave a fed, leave them dead. And we always said, oh man, we're going to give them Levophed, the patient's going to die. Current practices, again, we always go back to evidence-based medicine. Current practices, Levophed, leave them dead didn't mean that the patient was going to die. It basically meant that the patient had gotten to a point, perfusion-wise, that the only thing that would really help was norepinephrine. We want to use, at least it's for my agencies that I work with. Again, remember, this pertains just to your agencies as well. So what I talk to you about, it doesn't oversee or supersede your protocols, is that we like to use norepinephrine because it has less effects on the heart. You'd have to go and delve into the alpha and beta properties to be able to look at that. But basically what it does is it has less effects on the heart. And normally your norepi is going to be 2 to 20 micrograms a minute is what we're going to get. The other thing, and this again was very interesting to see during the research that we did, is that considering a higher peak in adult patients with sepsis-induced ARDS, we realized that if you consider using a higher peak in patients with sepsis-induced ARDS, that we were able to kind of reduce that as it went that way. I think the sentence itself on the screen reads a little weird. We're basically saying that we want to look at potentially using higher PEEP. And then another thing that I found very, 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 very interesting, I had never seen this before. I'd never heard of it before. I discussed it with one of our agencies just last week, that I know that I'm going to get a phone call from an ER saying, hey, your provider showed up in my ER, the patient was on a ventilator, and they were face down. Using a prone position over supine position in a mechanically ventilated adult patient, research has shown improves or reduces the susceptibility to ARDS. Basically what you're looking at, and again, you have to go and do some of your own research, just like I did, is that placing the patient in a prone position allows the alveoli to remain open when the intra-alveolar pressure exceeds the pleural pressure. So basically what you're doing is you're keeping those alveoli open, and the pressure is a little higher than it is in the actual lung itself. So again, something interesting to look at, something new to look at, and maybe something that the research is showing that works well, something we can consider doing. The next thing is the use of beta-2 agonists in patients with sepsis-induced ARDS, and that's using, what's a good example of beta-2 agonists would be stuff like albuterol in these type of patients to help in the process, and again, to reduce the susceptibility to ARDS.
Hey, Robert, before we finish up, let's can we go back to the previous slide?
Yes.
Now, you know, there's been a lot of changes in EMS in the past 20 years since we were young medics and EMTs, and one of the newer aspects that's out there is community paramedicine, okay, in regard, as well as advanced features within cardiac monitors, telemedicine, mobile communication, all these things combined. In your opinion, how do you see community paramedicine changing what treatments are available and what capabilities we're able to leverage in the field?
So in my opinion, I will tell you, I know that we don't do enough community paramedicine. It was interesting. I had found an old zip drive that I had put together back in 2007. And in the presentation that I had presented in 2007, I spoke about doing community outreach to our patients and doing community outreach to those patients that have that use 911 excessively. And it was weird because back in 2007, that was basically the framework that I had started looking at for community paramedicine. It's simple. You know, every morning in fire stations across the nation and EMS stations across the nation, we come in, we check our ambulances, we check stock levels, we make sure everything is good, and then we go and we run our calls. And then I'll tell you the truth of it is I would sometimes sit there and complain, oh, Miss So-and-so is calling us again for the third time today. If, again, my opinion, if as pre-hospital providers, we take 20 minutes out of our morning in preparation for the day to take 20 minutes to go visit a patient, to talk to them, to make sure that we get a set of vital signs from them to see that they're doing well, that we check to make sure that they've taken their medications, to make sure that their medications are up to date. Even something as simple as making a phone call for them and saying, hey, you know, I noticed that you have an appointment for today. are you going to be able to make that appointment? Or do you have a means of making that appointment? Just doing simple community outreach to these patients in your area, I think can lead to preventing what moves on to sepsis. Again, we talked about some of the things that lead to it. And by doing that, I think just the community outreach, I think it'd be very impactful.
You know, in considering, and you know, it was interesting, I didn't see it in the statistics, it's the incidence of post-operative sepsis. A patient goes home, they've been discharged after, whether it's a major and or, you know, minor surgery, and to your point, they don't take the prescribed antibiotics that they're supposed to be having, supposed to be taking, or they don't take them to their full extent. Community paramedicine may have an effect in reducing the incidence of sepsis related to post-operative care. Do you think that that's something that that community paramedicine might influence?
I think so too, and I think right now with the way the billing is coming around, the way medicine is changing, especially with having the patients that have to come back to a hospital after a procedure. Again, everything almost sometimes comes down to money. I think I was kind of looking at, I think the incidence of post-operative sepsis after elective surgery is about 1.7%. So I think that's still a significant number. And I think by doing this community medicine with these patients, I think that's going to greatly reduce the effect or the chances of sepsis. And it's going to greatly reduce right now I don't remember what the term is when a patient has to come back to the hospital within a certain amount of time. I think that's greatly going to reduce that, which overall should help reduce healthcare throughout.
Excellent. So you have some conclusions, sir?
Oh, yes, sir. I do have some conclusions. So let's kind of look at this. I think, again, instead of sitting there and reading this whole slide and telling you this is what the things that you need to do, it comes down to a very simple concepts. We have to recognize sepsis early, or the signs and symptoms of sepsis early. We need to be able to control the source of the infection. We need to immediately start looking at early antibiotics in the treatment of our patients. And we definitely need to look at early hemodynamic resuscitation. You cannot be scared of starting vasopressors on a patient that needs it. I think as medics, sometimes we are kind of scared. They're like, man, this is just something I've never done. It's above what I'm used to doing. We can't be scared. You know, we have to make sure that these patients are hemodynamically stable to prevent them continuing on to septic shock. The treatments, again, the treatment plan in most of our research that we looked at was pretty inconclusive. So that tells us that we're just not at the point yet where we know exactly what works and doesn't work. We did learn that the plans are pretty much harmless and that they may improve that sepsis survival dramatically. But we need to also make sure, again, I'm going to go back to this every single time. Your job as a medical provider is to prevent acidosis. If you can prevent acidosis by increasing the volume in the body, by increasing the volume in the vasculature, the chances of survival for the patient should greatly increase as a result of it. I want to thank everybody, and we're going to give it over to Max as well. I want to thank everybody for your time, for your audience. I will disclose that this is my first webinar, so I was pretty nervous. I've taught hundreds and hundreds of classes, but sitting in a room with nobody looking at me is a little off-putting for me. But I want to thank everybody for your time. I want to thank you again for your audience. And I want to thank everybody for something that we just don't do enough, and that's your dedication to learning. So again, thank you very much for having me. Max, I'm going to head it over to you.
Hey, thanks a lot, Robert. Good job on the presentation. I also wanted to add in regards to the conclusion and get your opinion on it. You know, it's maintaining that high index of suspicion that something is going on with the patient. I feel that oftentimes as a former paramedic that we'd arrive on scene and, we kind of get that first impression. We're like, well, they're not that sick. We can, they want to refuse. Okay, well, we'll let them refuse. And then like a couple of days later, you show up and they're, severely septic. And it's having that high index of suspicion and advocating for transport to your patient and or for the patient is critical in identifying and preventing severe sepsis.
Correct. I fully agree on that. And again, a lot of the agencies that I work with, they know that when it comes to treatment of patients, is signs and symptoms, vital signs are one thing, but I always will fall back on one thing that I think we all should do, and I think we all do actually as paramedics, and that's paramedic intuition. If you feel that this patient is sick or potentially might get sicker and the patient's like, no, mijo, I'm okay. And I say mijo because I'm in the San Antonio area. We get that a lot. Hey, mijo, I'm okay. I don't need to go. The hospital's so expensive. We need to really advocate for these patients. We need to explain to them what's going on, explain to them, the risks of what's going to happen as well. And I'll tell you, I don't think very rarely have I had a patient refuse transport, especially if my paramedic intuition tells me that they need to be transported.
Excellent. Thanks for that. Now is the Q&A part of the webinar where the audience can participate and ask questions. Heather will be presenting the questions to Robert and I, mostly Robert though. And keep in mind though that, some of your outstanding providers out there have a vast array of knowledge, and some of the questions may be out of scope to answer in the short time that we have. But if you have them, keep note, be advised that they are recorded. We write them down and we try to the best of our ability to answer them and then send them out to the audience. So without further ado, Heather, do you want to kick this off, please?
Yeah, absolutely. Thank you, Max. And Robert, I just want to echo the sentiments that Max stated. This has been a fantastic webinar. In fact, I'll kick it off with some feedback we got from the audience today. And one individual in particular said that he's been participating in a bunch of webinars lately, and this has been one of the best. He wants to thank you for the opportunity, as well as extend his thanks and praise to you, Robert, for teaching this course today.
Thank you. Thank you very much.
You bet. So the first question we have is, do all septic patients present with a fever?
So that's a great question. Again, we have to go back and refer to the stages of septic shock. Again, you have your hyperdynamic stage, you have your hypodynamic stage. Most patients are going to be sick for 3, 4, 5, 6 days before they decide they're going to call or seek out medical assistance. Initially, you're going to have that hyperdynamic state where your patient is going to be febrile. Most of the times as a pre-hospital provider, when we show up on scene, it's been a few days and the patient is now starting to lead to that hypodynamic stage. Don't be fooled by the fact that your patient has a low temperature. A low temperature is just as bad as a high temperature. So no, your patient doesn't necessarily have to present febrile in order for them to be septic.
Great, thank you so much, Robert. So the next question we have is actually a housekeeping item for logistics, and that is whether or not this webinar will be available for later viewing. Yes, the webinar is being recorded. It'll be posted online, and we'll make sure that all the attendees receive the information about how to access that. So thank you for your question. The next question we have is for Robert, and that is there a specific antibiotic that should be used?
So this is the time that I wish I had my medical director available. The man is a wealth of knowledge, and I will ask him a question and I will get a whole dissertation from him that I can actually understand at my level. We really want to look at broadband antibiotics. Kind of the way I look at it, and this is the way I kind of put it to people. Living in Texas, Texans love their guns, is that we can either A, use the shotgun approach and try to get everything that we can around us, or we can use the sniper approach and get that one specific problem. We don't have a way to figure out what type of infection or bacteria is in our patients pre-hospital. So for us, the shotgun approach kind of works better. We want to make sure that we get a broad spectrum antibiotic that acts against both something called a gram-positive and a gram-negative bacteria, in contrast to a narrow spectrum antibiotic. So we want to get something that's effective against multiple bacterial families as opposed to just a specific bacterial family. So again, your protocols, if you do have a sepsis protocol, is probably very specific. Our protocols for the Office of Medical Direction calls for cephalosporin, and that's the one that we like to use, but everybody's different.
Great, thank you so much, Robert. And the next question is simply looking for an opinion. So if you want to state any disclosures before answering, we completely understand. And that is, do you recommend 0.9% NS, normal saline, or LR for the fluids?
Okay, that's a great question. So I'm going to correct myself back on the antibiotic. We use cefepime is what we look at. Again, a broad spectrum antibiotic. And should I use 9% normal saline or lactated ringers? The research has shown that normal saline works effectively and works great with patients. Again, we're looking at wanting to increase volume, fluid volume within the vasculature, and normal saline would be just as effective. I really didn't look to see if there was one or the other. I think, again, the administrator in me tells me that usually lactated ringers might be a little more, so normal saline would probably be just as good.
Great, thank you so much, Robert. You're doing a great job with these questions today. The next one we have is, if you were the first responder on scene to send an incoming patient notification, what would be the content of that message or notification?
So depending on the regions and the areas that pre-hospital responders work in, a lot of them have what's considered their RAC, or their regional advisory councils. A lot of times these RACs will put together what we call sepsis alerts or sepsis protocols. I know locally here we do have a sepsis alert and sepsis protocol. I think what would really, really help is when you call in your report, let them know, I'm suspecting sepsis. The patient is either meeting QSOFA or SIRS criteria, or simply just letting them know, hey, my patient has been sick for a few days. Now they're, hypovolemic and altered mental status. I think a lot of times alone that will do it. Once you get in there, a lot of times the hospital personnel will identify it, and they'll even call an in-house sepsis alert as well. There is a hospital here locally that has an actual septic team that comes down and starts assessing, recognizing, and treating these patients as soon as possible.
Great, thank you so much. The next question we have is either for Max or Robert. It's about existing research out there. And specifically the question is, we understand that early diagnosis and treatment is important. Are there any studies that have shown improved survival rates or outcomes by starting treatment in the pre-hospital setting?
That's a good question for me, and without going back and reading all the ones that I have looked at, I cannot answer that question off the top of my head. So that leads me to believe that right off the bat, there necessarily isn't some type of advantage other than what was stated earlier: early recognition and transport to the hospital. Robert, do you have any opinion on that?
Pretty much the same. Again, there's a lot of research out there. A lot of the research really has been early and inconclusive. Again, always go back and do further research. When the question came up about normal saline and lactated ringers, it's possible that I think the person that asked the question was probably leading to a April 2018 article where they talked about whether lactated ringers is better than normal saline. The data right now is suggesting that it possibly is. But again, it's one study. We need to look at multiple studies. We need to really inform ourselves, and along with your medical director and your EMS boards, come up what's truly best for the patient. based on this research. I think in pre-hospital medicine, we're making huge move forwards for us now, starting to use a lot of evidence-based medicine and current best practice medicine. And I think that's what we need to do more than anything else.
Very well said, both Max and Robert. We have time for just a couple more questions before we get to closing remarks and sign off for the day. The next question we have is, what are some of the preferred pressors to use in septic shock?
So the two preferred pressors to use in septic shock right now are dopamine and norepinephrine. Again, we want to really look at norepinephrine as providers, really start looking more to norepinephrine simply because of the, again, the effects that, the reduced effects that it has on the heart than anything else. So right now, dopamine and vasopressor, basically, I guess, in one word. I know there's a few other ones that some agencies are using, neosynephrine being one of them that they're looking at, and that's actually the, I think the actual name, the other name for that one would be, I don't remember the name of it right now, but that's another one that they're kind of looking at as well. But really, norepinephrine has really been our go-to.
Great, thank you so much, Robert. And the last question for the day is, what would be the best quick sepsis assessment tool for EMS providers to save time and get a good grasp on the situation?
I'll go ahead and refer that one over to Max. Max was really good about looking at that and identifying that one for us.
That's a good question, and you know, as medics, off the top of my head, the best assessment tool that you can use is your five senses and your intuition to identify whether or not that patient is or is not septic. Because once you have that index of suspicion, then the things that you do after that, such as your you know, applying your monitor that has all of those, you know, capnography and pulse oximetry and all of those bells and whistles, right? If you don't have that high index of suspicion by assessing your patient properly, then you may not be inclined to utilize all of those features.
Thank you so much, Max. At this point, we are going to wrap up the webinar, but before we sign off, I just want to ask both Robert and Max if there's any final thoughts you'd like to share with our audience before we sign off. Robert, I'll start with you.
So my final thoughts: educate, educate, educate. Guys, go out there. There's a wealth of information that's available to you. Foam is one of the things that we talk about. There's numerous podcasts, webinars, just like today's webinars, articles all over the place. I'll tell you, I'm the guy that can look at an article and be like, or a research article and be, okay, I understand 3/4 of the language. If you look at it, there's numerous articles out there for pre-hospital personnel that breaks things down in 25-cent words. Again, I ask you to educate yourself. Don't take my word for it. I'll tell you that now as an instructor. If an instructor tells you this is why you do this, question it. Ask them, hey, where's the research behind this? A good instructor will lead you to the research and will give you the research links. Yesterday, I mean, honestly, I'm that nerd, that guy. I spent 3 hours in my vehicle to go pick up my kids from school. I spent 3 hours listening to a EMS education podcast while I was out there. So that tells you that it's readily available and free.
I think in the last minute. So I think in the last minute, you know, I once again want to thank everybody for coming, and then thank everybody for their service in EMS. It's difficult out there, and it's dangerous, and I appreciate everybody, all the hard work that everybody does.
Thank you so much, Max. At this point, we will be signing off today's webinar. Have a great day, everybody, and stay safe. Bye-bye.